All right, so you guys kind of, scoot around this way so you can get, so you can hear and see. Okay, all right. So, this station, we're gonna be talking about postpartum care. Okay, so this is where their moms have their babies, they come up to the mother-baby unit, so that's what we're focused on. We're gonna talk a little bit about what you would do immediately post-delivery in the labor and delivery, and then how that transitions into the normal postpartum period. So, let's just kind of talk a little bit about postpartum assessment and care. Let's kind of go through some of these questions first of all. So, the immediate postpartum period, right after delivery, what's that period? What stage of labor is that? Anybody know? Fourth, right, so it's the fourth stage. So, delivery of the baby and placenta are complete, right? So everything's happened, and we're focusing on, we wanna make sure mom is hemodynamically stable, that we manage her pain, and that she's physically and emotionally transitioning to our post-delivery state. So, usually in the United States, and keep in mind when we quote things and talk about, we're talking about how healthcare is in the US, and then there's always some outlier things, right? Things that happen that may be different. But usually, the mom and the baby are gonna remain in the labor and delivery recovery unit, or LDR, for about 2 hours. And then they'll transfer to the postpartum unit. So things that can interfere with that time frame of 2 hours can be any complications, so any hemorrhaging, any issues with maybe the mom's been anesthetized and she's like still really numb, with an epidural or something. So any kind of complications, anything out of the ordinary may lengthen that transition time. If their vital signs are not stable, okay? If they've had a pre-delivery complication like preeclampsia or severe hypertension that's requiring them to remain on IV medications that require closer monitoring, then they may not transition. So you think about a labor and delivery. In the OB world, labor and delivery kind of functions as your more critical care unit. So that's a unit where you can monitor people hourly or more frequently. So if you have somebody that's going to require hourly vital signs or an hourly intervention or an hourly check on a drip, they're going to stay in labor and delivery until that no longer exists. Your mother, baby, or postpartum unit is equivalent to like your med-surg floor. So those patients typically every 4-hour monitoring, that kind of thing, okay? Once they're stable after delivery, how long do they usually stay with a vaginal delivery in the hospital? Anybody know? 40 hours. Right, so about 48 hours. C-sections are a little bit longer, so we consider our vaginal delivery stay about 2 days. C-sections usually stay from 3 to 4 days. Sometimes you can have a C-section that goes home in 2 days, somebody that's, uncomplicated, the baby's fine, they've got some experience, we've assessed that, they seem to be able to manage the care and all that, they have good support at home, they may go home a little bit earlier. And then, the other things we're gonna talk about are just generally how do we care for this mom during this period. When you go over to the next section, you'll be talking about how we care for the baby immediately. Okay. So we have a first-time mom, she delivered 30 minutes ago, and we're assessing her, and we tell the mom, I need to check your fundus and your lochia. And our mom goes, huh? So what does that mean? How do we translate that into layman's term for our patient? What's fundus?
In the abdomen to check the position of uterus to see if it's boggy or not.
Right, so we're going to feel the top of the uterus, right? So the fundus is the top of their uterus. And then what's lochia? Right. So we have to remember that. We need to translate these terms into things that people will understand. So we're going to press on the top of the uterus, right? And we're gonna see what height it is, right, in relation to our umbilicus, right? Because remember, our belly button, our umbilicus is our landmark. So any distance above the umbilicus is a plus, any distance below is a minus number. Okay, and we use our finger breaths really. So we have +1, +2, +3, okay, to determine. And when we look at lochia, okay, so we've already talked about fundus. We want to know, is it hard or is it soft, right? Where it's located. Okay, we also want to know if it's midline or not, right? So if it's kind of centered or if it's tilted off to the side. And then we want to know about lochia. So what do we want to know about the lochia? The amount? Okay.
Initially, when babies are born, they're
Clotting or not.
Right, so if there are any clots in it, right?
temperature regulation
What else?
the newborn.
The color.
Right? So most of the time I'll tell you guys, we'll talk about different color of lochia, but most of the time you're gonna just see sanguinous pretty much. Maybe serosanguinous. You're not gonna get much past that in the hospital, right? Because these patients just go home too quick.
Usually we take initial set of.
What else do we wanna know? Anything else you wanna know about it?
Then at 30
Okay.
minutes.
Think about anytime you have a discharge from the body,
So in the initial stage.
how do we know if it's infected or not? What's one sense we use? Odor, right? So does it have a foul smelling odor? Okay. So, you know, normal bleeding smells like blood, it's kind of metallic, but is there a foul smelling odor? Okay, that's important to know because that can indicate some kind of infection, which may be an issue probably more for the baby than the mom, right? So we want to know that. Okay, good. So when we talk about how do we describe our fundus, right? We can describe it firm, right? So that means we basically touch it and it's hard as a rock, so it feels like your fist. We can describe it as firm with massage. And what does that mean?
You massage it to see if it'll contract and get firm.
Right, so when you first touch it, it's not firm, but as soon as you start rubbing it, tightens up real quickly, right? And then we can say boggy, okay? So when you think about boggy, think about squishy, okay? It doesn't have any tone to it. So firm, what is that? Good, bad, indifferent? Is that what we want to see? Okay, so that's what we hope to see. The uterus is clamping down. It helps manage our bleeding, right? Okay. Firm with massage. What can that be indicative? Why do we have a uterus that might only firm up with massage? What's wrong with it?
So their initial transition is
There's
from
some uterine
intrauterine
lining.
Right, so there could be something in it. Okay, that could also cause boggy. What else happens when you have a uterus that just only firms up with massage? Think about your person who's had a long labor, who's had a labor induction, okay? The uterus is a muscle, right? So it contracts, right? If you did this all day at the gym, right, you're gonna start getting tired, right? So your muscle's gonna start not wanting to contract. So your uterus is tired, okay? So a lot of times, just that simple massage will allow it to tighten up. Nothing's interfering with it other than the muscle fibers just don't wanna fire, okay? So you may see a tired uterus, a boggy uterus with someone who's had a long labor, maybe somebody who's had multiple births because it's been overstretched. And then what does boggy indicate? So what happens with when you have a boggy uterus? How does the uterus feel? Right, so it's soft and squishy. What happens to our lochia? We have more, right? So it increases. And then we also get what in the lochia? Clots, right? Because we have some pooling. So the blood will tend to pool inside the uterus instead of being forced out. And then when it finally gets forced out, when blood sits, it clots, right? So that's why you're gonna see clots with a boggy uterus. And then the clots collecting in the uterus further inhibit the the ability to clamp down, because now you're filling it and it's trying to clamp down around clots, okay, so it won't work as well. And this is gonna put a mom at risk for a postpartum hemorrhage, okay, so we wanna watch these patients. Normally, where do we, right after delivery, where do we hope to see the uterus? What's its position?
You just kind of pinch the bottom, you can palpate.
Do we wanna see it midline, left, right? Midline, right, okay. And then how high do we want it?
Right at or below the.
Right, so right about, right around the umbilicus, right? Good. So when we talk about documenting our lochia, we're gonna use terms, specific terms. They may vary slightly depending on where you're documenting at, what facility you are. But generally, we're gonna use what's the least amount that we usually document as? So that's gonna be scant, okay, scant, light, moderate, or heavy. They're somewhat subjective, okay? So a scant amount of lochia is just gonna kind of be like spotting, not much. You're rarely gonna see a scant amount of lochia in the 2 days that the patients are there, but you might. Light, okay, that's going to be, maybe, this much on a pad over a period of, 2 to 3 hours, okay? Moderate is going to maybe be about half the pad full, and heavy is going to be, the pad gets saturated. But remember, these terms are related to time as well, okay? So when we get into our assessment, we'll talk about, we wanna confirm, how long has that pad been on there, okay? So a saturated pad that's saturated after 4 hours is different than a saturated pad that's saturated after 15 minutes, right? So it does depend on our time frame as well. Okay, what organ can displace the uterus and interfere with the ability for it to remain contracted? Bladder, I heard bladder, right? Okay, so what do we do?
Try and get them to void.
Right, so first thing is we wanna get our patients up to void. If you think about the process, so they've delivered a baby, okay, as the baby's come through, it's kind of compressed the bladder, compressed the ureters. They might have some swelling around the urethra, right, because of all of that, the pushing and all that. And then on top of that, they might have, maybe they had an epidural or spinal anesthesia with a C-section, so they don't have the same sensation. We may need to, prompt them to get up and void and empty their bladder, okay? What do we do if they can't void? How are we gonna empty their bladder? Right, so we'll do a straight cath. We will wanna do that to ensure that our uterus can clamp down, right? So we don't want the bladder interfering with that. So we're gonna, we can use our term bubble heat to do our postpartum assessment. So as we go down, what's the first V? Breast. Okay, so think about, I know you guys are like, oh God, this is a quiz. Okay, think about top moving down the body, okay? That'll give you a clue. What's next after breast? What do you think we look at? Uterus. That's okay. B. Okay, another B. What else goes with the bladder? Think output. Bowel, right? Okay. L. Yep, because you're down in that area, right? What's also down there? E. What are we looking at in the perineal area? What are we looking for? Okay. What's the incision called that we make?
Oh, episiotomy.
There you go. So you're looking for episiotomies, laceration, so you're assessing that. Okay. What's H?
Holman sign.
Okay. We're not using Homan sign as much. What other H can you use? It's not wrong. What's associated with the bowel that's an H, that's an abnormality that you might see on the rectum? Hemorrhoids, good. Okay, what's E? Okay, so we've done all the physical stuff.
Oh, emotional.
Right, so, yeah, so we don't wanna forget that. Good job. So we're gonna talk in more depth about these things. How can we, what's the best way, how do we wanna position a mom to fully be able to access her lochia and look at her perineum? What position do we want her in? Pardon me?
Like
If their
upside
cry
down,
is weak
with
or
her-
if it's delayed.
like supine?
So you can do supine, what else? How are we gonna look at her hemorrhoids?
Side.
On the sideline, right? So if, exactly, so if you do a sideline, it's called Sims position, sideline, they pull the top leg up, right? Then you can gently, with your gloved hands, kind of lift the top buttocks, and you get a nice, good view of the perineum. You can see if there's any swelling, you can see if there's any hemorrhoids, you can, get a good look at the perineum to be able to assess that. So first you wanna look on her back and check what's on the pad, but then you wanna get her rolling over to her side so that you can assess, the perineum. Okay. So in the first 24 hours of delivery, okay, we're gonna talk about how frequently we're going to monitor our vital signs. So initially in the labor room, that's gonna kind of include also looking at the baby, which Ms. Snipes will address. But, so initially when our patient delivers in the first hour after delivery, so immediately after delivery, how often do you think we're assessing vital signs?
Every
15 minutes, good, okay. Then the next hour, how frequently? 30, right? And then the next 4 hours, how frequently? Hour. And then after that, how frequently? Every 4 hours, right? So, every 15 minutes for the first hour. This is for a vaginal delivery. If you have a C-section, we go by PACU and operating room nurse standards, and so we're actually assessing our patient every 10 minutes, because that's an OR thing. But close enough, you know, so, every 15 minutes for the vaginal delivery for the first hour, then 30 minutes for an hour, then hourly for 4 hours, and then every 4 hours for the first 24 hours. After that initial 24-hour period for our vaginal delivery patient, we can go to, Q shift, Q 8 hours, it depends on how your facility defines it. Lots of people work 12-hour shifts, so it depends on how they assign it. If you have a C-section, it's gonna differ slightly, okay? So as long as they're in the PACU, and they're in that immediate period, you're going to, assess them every 10 minutes for the, as long as they're in the PACU. Usually they have to stay in the PACU a minimum of an hour. That's an operating room standard. So they're gonna go sometime between an hour and 2 hours to the postpartum area. Then you're gonna go to the every 30 minutes times 2, hourly times 4, every 4 hours. But because they're considered a post-operative patient, your post-operative standards differ slightly, and those patients will need to be every 4 hours for the first 72 hours, okay? So pretty much the whole time they're there. And that's related to their post-operative status, okay? So it's a little bit different. All right, okay, so we have a patient who delivered an hour ago, and this is her assessment. Her fundus was firm with massage, U+2, so heavy rubra lochia, and her bladder is empty, okay? Is this a totally normal assessment? Okay, no. What's abnormal about the assessment? Fundus firm with massage, is that totally normal? No, okay. U+2, okay. Heavy rubra lochia, is that a problem? Yeah, okay. Bladder's empty, that's good, right? Okay. So, so what's going on here? Okay, so you have, when we say we have a fundus that's firm with massage, what's wrong with our uterus? It's not contracting because it's tired, right? Okay, our bladder's empty, so that's not interfering with it. We do have some heavy bleeding probably because our uterus isn't firming up. What might we need to do with this patient? Okay, we don't need to empty their bladder, okay, because their bladder's good. What's the next thing we might consider? Pardon me?
The bleeding, taking care of that.
Right, so how are we gonna make her uterus contract? Pitocin, right? So we're gonna look at medications, right? Because once the uterus contracts, that should slow the bleeding if it's coming from the uterine area, right? Okay, so we're gonna consider giving her Pitocin. Tell me basically 3 things you would want to teach your postpartum patient. So everybody's gonna get a chance. So tell me one thing you would want to teach a postpartum patient.
Avoid heavy lifting or exercise immediately after.
Okay,
The importance of walking every day when she gets home.
okay, so we've got avoid heavy exercise, we've got walking and ambulating, okay?
Sits
But
back.
our range of
Okay.
EMH is 110 to 160.
Maybe
I think I read
the
somewhere.
pain, not pain, but like,
Somewhere around
do they help with the perineal area?
Yeah, with the swelling,
Swelling,
So sits fast to relieve pain and swelling.
To educate on fluid retention, because it might hurt to pee, but it's good for her to like empty her bladder often.
Okay, so emptying the bladder, good.
Inform her and her family of first signs of postpartum depression.
Right, so teaching the patient about postpartum depression, okay.
Small amounts of bleeding are normal after birth.
Pardon me?
Small amounts of bleeding may happen.
Right, so she's gonna continue to have lochia, good.
What's her diet?
Okay, so the importance of a good diet to support breastfeeding, to support recovery, right? Okay.
Also with the bleeding, like the size of clots
And
that she would
sometimes
have to come back in, or more regular blood pressure that she might have to come back in for.
Perfect. So thinking about when do you need to return to the hospital? What are some danger signals? Good. Okay. So, we also might talk about newborn and infant care, hygienic practices, okay, birth control, how the lochia is gonna progress from being sanguineous to alba, right? So what's alba? What color is alba? Anybody know?
And it's just a little sticker that goes on the.
It's white, so think about albino, white, alba, okay? So it's white. So we're gonna progress from sanguineous, which is bloody, to serosanguineous, which is pink. We might have some, and we describe it as rubra, right? We might have, some dark brown discharge as the blood is getting old, and then it's gonna turn to white alba, which is mostly our extra cells and stuff sloughing off finally. Okay, so that's how, and that's gonna progress and decrease in amount over about, 6 to 8 weeks. Okay, so let's think about our assessment. So one of the things that you wanna think about when you're going into your assessment of a postpartum patient is you wanna think about, do they have any risk factors as well as you're approaching your assessment? So do they have diabetes? Have they had a prolonged labor or precipitous labor? Were they a cesarean section, multiple births, hypertension, preeclampsia? Because that is also going to focus your assessment and maybe add some things to your assessment to think about. Okay, so the first thing, what's the first thing that we do when we physically assess every patient that we go see, no matter where they are?
General appearance.
Pardon me?
General
Your
appearance.
baby
So general appearance, what's next? What else do we do?
Sometimes you'll see them.
Vitals.
Vital signs, right, so vital signs, they may have a slightly elevated temp, up to 100.4, that's kind of normal after delivery. Delivery is an insult to the body, okay, it's a change, they may have an episiotomy, they may have lacerations, so their body's gonna kind of, start an immune response, okay, so they may have a low-grade fever. What about our lungs? How should our lungs sound?
Clear.
Clear, right? So we shouldn't expect to have any problem with our lungs, right? Okay, so we're gonna do those things. So we're gonna listen, don't forget your heart and lungs. I know these are pregnant patients and we're focused on everything else, but general appearance, vital signs, heart and lungs. Always go with it, right? Okay, so then what's our first B again? Breast, okay. So, when you, go into your room, you're gonna hand sanitizer, of course. You're probably gonna put gloves on because you're gonna make your way down to the perineum. But when you go in, you're going to want to say, hey, Miss Smith, I'm Kathy, I'm your nurse, I'm gonna do an assessment on you. Get your vital signs, how are you feeling? Are you in any pain, right? These are all part of our assessments. And then I'm gonna say, I'm gonna do a physical exam, so I'm gonna start with your breasts and just kind of make my way down, okay? So you're gonna wanna uncover, you can uncover one at a time, okay? What are we looking at when we're looking at breasts? What are we assessing for?
And then when they go upstairs to family care, they get a.
Right, so we wanna see, are their breasts filling? So what's the milk status? So when does milk come in? Anybody got like a clue?
Basically.
Okay, about 2 to 3 days, okay? So we're immediately postpartum or in our first day, we're going to basically expect a soft breast, okay? So we're gonna have to palpate, right? Okay, we're gonna inspect. What else? What about the nipple?
It
What-
shouldn't be cracked.
Pardon me?
It shouldn't be cracked.
Right, right, so it shouldn't be cracked. If she's breastfeeding, right, we need to know, how does the nipple look? Is it reddened, is it cracked, is it bleeding? Okay? We also wanna know, is it everted, is it inverted, is it flat? Because that's gonna affect the breastfeeding, right? So, this mannequin here has a nice everted nipple, but if you have an inverted nipple, that nipple is gonna be recessed, and if you think about how a baby nurses, it's not gonna be a lot for that baby to grab onto, okay? So, hopefully patients who have inverted nipples and want to nurse have been working during the, prepartum period to kind of roll the nipple, pull it out, break the scar tissue that's holding that nipple inverted, okay? All right, so we're gonna do our general inspection. We wanna check our nipple. We wanna see, how our breast looks, right? We wanna, assess if they're having any difficulty or pain, related to their breast, okay? So we'll do one side, and then we'll uncover and do the other side, okay? So what's next? What's our U? Uterus, okay? Okay, Miss Smith, I'm gonna come down and check your belly, okay? So, you know, again, you can keep her covered, expose her uterus, right? We're gonna wanna look, okay? If it's a, C-section, she's had a C-section, we may wanna go ahead and listen, ask her, you know, are you passing any gas? It's all kind of interrelated, but now we wanna palpate her uterus, right? So we're gonna I'm gonna press on your belly a little bit. I know that it's gonna hurt, but I'll try to be gentle. So you're gonna support down here, find your umbilicus and press down. Now, if you press down slightly and you feel that nice hard, you don't have to do a heavy massage, okay? We just need to locate it. But if you're having trouble locating it, you may need to push deeper, okay? If you have women who are very thin, you literally can, you know, see where their uterus is, okay? If you have somebody that's obese, you may need to push a little deeper to find the uterus, okay? And then what are we assessing with the uterus again? What do we want to know? If it's firm, if it's midline, right, our location, and then we want to know in relationship to our umbilicus, right? So we're going to put our fingers and see, oh, this is, you know, U plus 2 or U minus 1. Okay. So we've done that, okay? We're looking at the uterus. If you have a patient that has had a C-section, of course, this is the prime time to check their incision out on their abdomen as well, right? So we're gonna assess our incision. So what are we, looking for? Pull it back out of your brains first. What are we looking for incision? Anybody remember the mnemonic when we're looking at incisions?
I don't routinely give this as an.
It's REDA, right? R-E-E-D-A. So we're looking for, what's R? Redness. E? Pardon me? Ecchymosis, edema, erythema. Okay, so, what's D? Drainage. What's A? Approximation, right? So good. See, in there somewhere. Okay, so you're gonna inspect your incision, okay? In labor and delivery, in the obstetric area, most of your patients' incisions, when they do a C-section, they're gonna close the incision with surgical glue, okay? When they use surgical glue, it dries to the purple color. It almost matches those gloves. Those, purple, your non-sterile gloves, it's about that color. You won't generally have a dressing, okay? So even they come out of the OR with no dressing, okay? Unless they've had a little bit of discharge or something, they won't have a dressing. So you'll be able to inspect their incision using our Rita component, because we're right there in the abdomen, okay? So this is the prime time, right? Because you kind of want to move down. Okay. So you okay? Yeah. Go ahead. So B, what's the next B? Bladder. Okay. So again, we're right here, right? So we're going to kind of assume if our uterus is midline and about where we expected, our bladder's probably not full, right? Okay. What might we consider doing prior to even starting an inspection? Like we go in first thing in the morning, our patient we think's been sleeping more. What might we suggest our patient do prior to our exam? Pardon me?
Drink fluids.
What else?
Go to the bathroom.
Go to the bathroom, like we don't have to pee first thing in the morning, right? You have to get up. Because that'll, one, make it more comfortable, and two, make our assessment more true, right? Okay. So that may be one of the first things that we ask the patient. We're gonna inspect their bladder. Now, honestly, sometimes in labor and delivery, if you've got a bladder that's really full, like someone's had an epidural and then hasn't had their bladder drained, you can palpate a bladder, but it is not normal to be able to palpate a bladder. I mean, if you can palpate a bladder, you better go get a catheter or have this person board right now. Because you're not normally going to be able to see that, okay? But you can assess how can we assess their bladder besides, just looking? What else do we do with our assessment? How else can we tell our patient to assess their bladder? What else can we ask?
The color of their urine.
Right, when they last voided, all of those things. Because some things we're just gonna ask questions. Remember, that's part of our assessment, is we can ask questions. Okay, so we might ask them, when did you last empty your bladder? If they haven't gone up, like if we didn't just come in the room and say, do you wanna go to the bathroom first, okay? If they did, then we know, right, as part of our assessment. Okay, what's the, so we've done our bladder, what's our other B? Okay, so how do we assess somebody's bowel habits? We ask them, right? Have you had a bowel movement since delivery, or when was last bowel movement, okay? It's not abnormal for patients to not have a bowel movement till, a couple of days after delivery, okay? Because are we feeding people when they're in labor? No. And then when they go to deliver, if they have a vaginal delivery, what happens if you think of the rectum, right? So, and the vagina, they collapse, right? And the bowel gets essentially evacuated, right? So the poop comes out. So then they've got to have some nutrition in. So it may take them a couple of days before they have a bowel movement. Your patients that are C-sections, what do we know that, what things do we know that contribute to slowing down the bowel? Anesthesia, right? What else? Not moving as much, okay? If they're on pain meds and narcotics, right? So we know all those things. So that's gonna contribute to this slowdown, okay? What else? Do you think if someone's just had a baby coming through there, they feel like bearing down and having anything else come out? No, right? So there's a little bit of fear, about that. Maybe they have hemorrhoids, that's gonna interfere. So we have to, think of all these things. So that's how we pretty much assess for their bowel. Okay, what's the L? Lochia. So we're gonna look. Okay. So we're gonna look at our patient. Oh my. Okay. So, Mrs. Smith, how long has this pad been here? I think since last night. So we're not real worried about it, right? 8 hours, not too worrisome. 1 hour or less, very worrisome, okay? So we're gonna assess her look, what amount is it? What color is it? Some of those kinds of things, okay? Then what's E?
You also see them come out with,
Huh? Episiotomy, right? So we're gonna say, Miss Smith, I'm gonna get a good look at your bottom. So I'm gonna have you, I'm gonna have you bend your knee and then roll over. So we're gonna have her roll over, okay? Then you're gonna feel me touching. I'm just gonna lift your top cheek and you're gonna look, okay? So you're gonna look at, is there any swelling and edema in the bottom? We're looking at, does she have an episiotomy? We should have got that in report, right? So we would know. Or any lacerations? What's the difference between an episiotomy and a laceration? A basic difference.
Episiotomy was intentional.
Right. And laceration is unintentional, right? Okay. Are all lacerations, are they all gonna have stitches in them? No, right? Just like, you cut yourself, you don't always put a stitch in everything. So, we'll need to know, do they have stitches? What does it look like? Again, we're kind of doing the Rita thing, right? Is it red? Do we have edema? Do we have erythema? Is it any drainage? And is it approximated? Okay. You have to be careful because when you have lacerations, that sometimes if the skin sits nicely together, they may not put a stitch in all of those. So sometimes when you're lifting the cheek, you're gonna kind of spread the laceration a little bit, but if you let go and you can see that it's well approximated, it's considered approximated, okay? Not that you can pull it apart. So we're gonna look for all of those things, and then, what's H? Pardon me? Hemorrhoids, so we can look while we're there, right? So we're gonna see, do they have any hemorrhoids? That may, deal with how we decide to, deal with their constipation, right? So we might give them stool softeners ahead of time, trying to combat that. Okay, and then what's our final E? Okay. So, how are you doing today? How's breastfeeding going? How's the baby been? Did you get any rest last night? Just kind of general questions to assess how their emotional status is. Do they have a flat affect? Are they disengaged? Do you have somebody that's overly weepy? Do you have somebody that's, that seems appropriate? That's bonding with the baby, that wants to hold the baby, that kind of thing. So you're gonna, assess their emotional status. All right, good. So that's gonna kind of be, how you do your assessment immediately after delivery, but it's also how you're going to kind of do your shift assessment when they're out on the mother-baby unit. Every time you come to work and you assume you're home.
So that's gonna be part of your effort, because you're checking their reflex.
And then we also, we also want to remember that, besides assessing their emotional status, we want to check for edema in their lower extremities. How does that look? It's normal for our pregnant patients to have some edema. It should get, will get better. But we want to assess that, and determine how much edema is in their lower legs.
If the baby comes out crying, pink, and moving, you can almost 100% tell your heart rate.
Why are pregnant women at increased risk for deep vein thrombosis or
But
thromboembolism?
yes, everything is done in like one sweeping motion. So you're stimulating, you're
What
looking
makes
at the
them at
baby, you're assessing their reflex, you're both suctioning all at the same time. When you use the
So
both
first of
suction-
all, their
Dr.
blood
White,
tends to
yes.
be
Do you have a both
hypercoagulable, okay? Just the condition of pregnancy. So that's why they're more at risk, and so that's why we worry about blood clots in our pregnant patient population. So we want to make sure that our patients are getting up and moving. We want to make sure that our legs are not bilateral, or more swelling on one side than the other, right? Oh, okay.
We'll initially get a suction box
So you wanna make sure about that. Okay. What other, and we kind of touched on it, as we're doing the emotional status, we wanna talk about rest. Okay, how can they ensure that they get some rest, okay? And then also about the importance of the nutritional status.
It's 50?
Yep, I'm good.